It's showtime. Okay, let's see why we don't have any sound.
Nothing
Good morning, everybody. It's December 6th. It's 2011. It's 9:35 in the morning in the beautiful island of St. Kitts, which you see the map of. And I took a look at my list today to see all the things I wanted to announce or talk about before we get dirty again. And there's nothing on the list except for the date. So that means we must be getting used to the whole routine here. We will be talking about anemias today, and we spent a lot of time generally discussing them and going into the classifications and reviewing a lot of the normal anatomy and physiology. So today we'll probably spend most of the day talking about actual anemias, unless you could think of something else you want to talk about. It's a good day. I noticed that when I go into the details and a lot of the background of the relatively sketchiness that are on my PowerPoints, it often takes about twice as long as it usually takes. But that's okay for me, because I also noticed that if I took all of the hours that I had allotted last year without any time constraints for both general as well as systemic pathology, it came out to 140 hours. And I think if I added up all the hours that are allotted to your butts sitting down on those chairs this year, it's about twice as much. So that's fine with me. I generally think that you should never try to schedule or allot time for teaching. I just think you should cover the material, whatever you think is necessary. And if you get done early, fine. If it takes a little longer, fine with that. So, usually after the first session, I probably would have been about done or almost done with the anemias. But let's take a lot of time to actually get into it in a very detailed, hopefully logical pattern. And I guess a good place to start is where we left off yesterday. So if you remember yesterday, we talked about the modifiers of anemia, the clinical modifiers, the words that you could use just by looking at those cells in the laboratory, whether they're small, whether they're big, whether they're pale, or whether they show a lot of variation in sizes. So that would be microcytosis, macrocytosis, hypochromia, and anisotosis. And most of the anemias that we'll be talking about today, certainly the hemolytic anemias, and then in the anemias of impaired production, we're going to be talking about these types of cells. Okay, so here it is. Hemolytic anemias at the top of the list. We said that hemolytic anemias are anemias in which red cells, for some crazy reason, genetic, acquired, something to do with the hemoglobin, something to do with antibodies, for any reason all, that red cell is not healthy enough to live its normal lifespan. So it gets destroyed earlier. Now I said technically less than 120 days, but most of the hemolytic anemias are a lot less than that. So, you know, if you're supposed to live to be 80 years old and you only live to be 75, you know, that's no big tragedy. But if you are statistically, according to the U.S. government, supposed to be 83 if you're a woman and you only live to 43, you know, there's a serious problem there. You've died before your time. So most of the hemolytic anemias have cells which live a lot less than 120 days. Sometimes 30, 40, 50 days. And there are studies that you could do with isotopes that'll measure, you know, the theoretical lifespan of your cells. Also remember, and I'm sure I'm going to put this on the exam, because if you miss this or you haven't gotten it already, it's the key feature. The key thing that differentiates the hemolytic anemias from the non-hemolytic anemias, or the anemias of impaired production, is erythroid hyperplasia. And remember, from physiology, there are physiologic mechanisms, signals, so to speak, to determine when you are anemic, to send signals to your kidneys, of course, which is the organ that makes erythropoietin, or EPO, to pump up the juice and start making some more. So in most of the hemolytic anemias, in fact, we'll say all, just to be logical here, the body knows you're anemic. It sends the signals to the EPO, the erythropoietin, and it results in more red cells being made in the marrow. So an anemia of impaired production is not going to have a high erythropoietin level. That'd be a great test to do. Your patients come in anemic, and you go, well, I remember there's two kinds of anemia, the hemolytics and the ones that due to impaired production. Let's just do a serum EPO, and if it's elevated, then we'll know what type it is. Well, that's not really done, but that's one of the common features. So a marrow hyperplasia is about a sine qua non for a hemolytic anemia, which means you absolutely have to have it, because in every case where your cells are dying, there are mechanisms to pump into that marrow, and maybe other places too, like the liver and spleen, to tell the marrow to start making some more. Now, it's not, doesn't take a rocket scientist to figure out either that in the normal death of a red cell, which usually takes place in the spleen, of course, but if it's really severe, it could take place inside the blood vessels, if it can't wait to get to the spleen, or both places. If a red cell is basically a bag of hemoglobin, and you're breaking down that red cell, you're going to get heme, and you're going to get globin. And the heme is going to have iron, isn't it? And the globin is going to be the protein part, isn't it? It's going to have 2 alpha chains and 2 beta chains if it's normal. So think about a red cell breaking down, and what are the products, the catabolic products that are involved in the breakdown of the cells? Well, how about bilirubin? Okay, we know that if you look at the so-called bilirubin cycle, bilirubin is a breakdown of heme, isn't it? It doesn't have the iron part, but it has the heme part. And what about serum hemoglobin itself? If there was theoretically some process, rupturing all of your red cells right now, all that hemoglobin inside your cells would now be inside your serum. So usually in the more severe or acute hemolytic anemias, you're going to have free hemoglobin floating around in your blood rather than wrapped up nicely in little bags, which are biconcave discs called red blood cells. In addition, if it is more of a chronic process, that iron, which is released freely, has an iron cycle, which we're going to talk about when we get to iron deficiency anemia. And you can imagine, I don't think we've seen this yet, but any place where you have a breakdown of red cells in the body, that iron is eventually going to be inside of that little area, isn't it? And you do know that the end storage product of that iron is going to be a pigment called hemosiderin. Okay, and it's also the hemosiderin that acts as the storehouse for iron. There's a couple of other proteins intermediate. So in the breakdown of red cells, you'll see hemosiderin because it's probably the most common endogenous pigment that you'll see in the body under a wide variety of conditions, both normal and abnormal. And as long as I said most common, let's take one of the most common diseases in the world. Let's take heart failure. Well, what happens if there's heart failure? Especially a left heart failure, for example, if you want to divide into left and right. Well, in the left heart failure, you can't keep up with the demands coming into the left atrium and left ventricle because you have primary left ventricular failure. Therefore, the blood backs up in the lungs, doesn't it? And your lungs become congested, doesn't it? And I know you went over this in the hemodynamics chapter because Dr. Jalan told me he spent a lot of time with you on hemodynamics. So those red cells are now congested, they're hanging around, they can't go anywhere. They eventually break down. So they eventually, not acutely, but chronically, weeks, months, will form hemosiderin. The hemosiderin goes inside of macrophages because there's no other cell in the body that can chew up hemosiderin. Think about it. And now you cough. And so everybody coughs. But let's say somebody with chronic congestive heart failure coughs. Well, some of those hemosiderin-laden macrophages are in the sputum now. So think of it as a very primitive way of measuring congestive heart failure, is to do a stain on somebody's sputum and look for those hemosiderin-laden macrophages. Another common word for them is dust cells, but I don't know if that's really a word that is used too much anymore. I know it's in some of the books. Okay, now another thing to remember is that hemoglobin doesn't like to float around all by itself in the blood when it comes from the red cell. It loves to be picked up by a very, very rather specific protein, which I think is made in the liver, which is called haptoglobin. So, what I've just described are all the common lab tests that you can order, you can do, you can see, you can assess in a hemolytic anemia. Serum bilirubin is up. The more hemolytic, the higher it is. By the way, is that bilirubin going to be conjugated bilirubin or unconjugated bilirubin? Well, remember, it's being released from the red cells. It hasn't had time to go to the liver yet to become conjugated. So for the most part, the bilirubin of hemolytic anemias is unconjugated. Now, do you remember the bilirubin tests called the direct and the indirect? And maybe you're a little confused about that, like I was confused most of my life about it. But just remember it this way. If the bilirubin is a hemolytic bilirubin, it hasn't been conjugated in the liver yet, it's unconjugated. And therefore, it will show up as increased on the indirect bilirubin test. Unconjugated, indirect. Now let's say that bilirubin is now conjugated in the liver, and it builds up because maybe there's an obstruction to the liver. Now, it's already conjugated though, isn't it? So that's the direct method. So to make a very, very complex biochemical process very easy, hopefully, or oversimplified, because there's no such thing as oversimplified, unconjugated bilirubins are generally present in hemolysis, hemolytic anemias, measured by the indirect test, and conjugated bilirubins are measured by the direct test, and that's bilirubin that's already been conjugated. And the jaundice of a conjugated bilirubin is a compound now that's already been conjugated. In the process of conjugated, it becomes more soluble in water. That's one of the things that conjugation does. So the jaundice of hemolytic anemia is less likely to be soluble in aqueous parts of the body, whereas the jaundice of a post-conjugated bilirubin, let's say an obstructive liver disease, carcinoma of the head of the pancreas, for example, would be more likely to be soluble. Okay. Probably so your patient's bilirubin is up. If it's unconjugated, think of a hemolytic anemia, because that's what it's going to be most of the time. Let's say that there should be no or very, very, very little free hemoglobin in your serum, because all the hemoglobin is supposed to be in the blood cells, right? But let's say you do have a elevated serum hemoglobin. Well, think of hemolysis. Now, you're not going to get a serum hemosiderin, because remember, hemosiderin is stored in tissues like the bone marrow, like the spleen, like even the liver to a certain degree, maybe in bone marrow where there's a lot of macrophages. But what about a haptoglobin? If that free hemoglobin loves to be picked up by haptoglobin, probably the single best clinical lab test, which is done all the time, to detect the presence of a hemolytic anemia is a serum haptoglobin level. Okay, hemolysis. Well, by now we've talked about it in all directions, and you know it could be intravascular, which means the cells are dying in the blood vessels. Most likely in a normal fashion, in a less of an acute fashion, the hemolysis goes on in the spleen. And that's where normally your 120-day-old red cells go to die anyway. And of course, the more acute, the more severe a hemolytic process is, the more likely it's to occur in the vessels rather than the spleen. Okay. So, remember, we've talked about this a couple times already. We've introduced the concept of an ME ratio. This is very, very important in the evaluation of a hemolytic anemia. Because if I told you, and I think you understand why now, that there are approximately 3 times as many myeloid cells in your bone marrow as there are erythroid precursors, then that's called the ME ratio of 3 to 1, isn't it? But wait a minute, but let's say that you're hemolyzing and now you have an erythroid hyperplasia. Well, the denominator just got bigger, didn't it? So that means that ratio is going down. So one of the most common reasons for a decreased ME ratio would be hemolytic anemia. And in most cases of hemolytic anemias, it's very often not 3 to 1, but it's already down to 1 to 1. Or it could very easily be reversed as well. Now this happens to be a pretty nice smear here, and the reason why I like it is because on this particular stain you could easily tell the difference between myeloid cells and the erythroid cells. You want to know why? Because all the erythroid cells have very dark, round, maybe even almost black nuclei, and all of the myeloid cells have kind of a reddish, less dense one. There's a myeloid, there's a myeloid, there's a myeloid, 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 myeloid. I bet you, if I asked you to count the myeloids here, you'd all come up with a number around 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. About 26. So normally, for every 26 myeloids, you should see about, 8 erythroids? But look, how many erythroids do you see? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. So you're seeing about an ME ratio here of about 1 to 1. It's a decreased ME ratio simply because the erythroids are hyperplastic. Now I want to warn you about something. This is only a ratio. That's all that it is. It's just a ratio between 2 numbers. It's not an absolute number. So let's say you can have an altered ME ratio simply because of a hyper or a hypocellularity of either one. So an ME ratio of, let's say, 3 to 1 or 2 to 1 or 1 to 1 doesn't really mean much by itself. You have to look at the overall cellularity of the bone marrow as well. And we said that normally a cellularity is about 50%, right? Half hematopoietic cells and half fat. Let's say the cellularity was 10% or 90%. Well, then that ratio takes on a whole different meaning, doesn't it? But here's the bottom line. If an ME ratio is normally 3 to 1, and it is now lowered because of a erythroid hyperplasia, and nothing changes with the myeloids, that means the cellularity is going to be increased, doesn't it? Okay, good. You got the concept. So let's move on. Okay, this is the first hemolytic anemia on our list technically, because remember, we're going to start talking about genetic reasons why red cells don't last their normal 120 days and fall way, way short of that? Well, the most classical genetic disease that results in a hemolytic anemia, I shouldn't say that, because probably sickle cell is probably even more classical. But it's the concept of hereditary spherocytosis. And you know it's hereditary, which means you know it's genetic. It happens to be autosomal dominant, so all you need is one allele. And when I told you before that red cells are nothing but a bag of hemoglobin, you know, I lied. It actually does have a little bit of an internal skeleton, and there are proteins on the inside of that red cell called ankyrin and spectrin, and they basically give that red cell its normal biconcave shape. Well, let's say that you had a autosomal dominant disease that wound up, there's a variety of genes, there's about 5 or 6, but a lot of times they start with ANK or SPE, so you know it's going to be an ankyrin or spectrin gene. Well, let's say that ankyrin and spectrin now, this internal cytoskeleton for the red cell, for some reason, just is not working, so your skeleton fails. Well, let me tell you something. If your skeleton failed right now, you would turn into a blob, wouldn't you? And if a red cell skeleton fails, it no longer can keep that nice little supple biconcave appearance. It turns into a blob. It turns into a sphere. And it might start by having little membrane blebs and problems, but ultimately it's going to turn into a sphere. So when you look at hereditary spherocytosis in a peripheral smear, it's not going to have that nice normal central pallor because it's a biconcave disc. In this case, some of them do have a nice central pallor, but a lot of them, they just look like they have no pallor, which means they're not biconcave, they're just red, probably spheres. And remember, it's not all the cells. It could just be half the cells. It could be less than half. But when you see a cell that's smaller, that doesn't have a pallor, and a lot of them don't, think maybe spherocytosis. And can I ask you another question? Let's say that you put this patient through the big chug-a-lug hematology machine in your lab, and it spits out a number called a MCV, mean corpuscular volume. Well, if a lot of these spherocytes are a hell of a lot smaller than they should be, like here, and here, and here, and here, and here, then how is that going to affect the mean, M-E-A-N, or the average volume of an erythrocyte? It's going to make it go down, isn't it? So it has a low MCV, which means it's a microcytic anemia too, isn't it? Okay. So very often, depending on the genetics of the case, children have it. It's pretty obvious soon after birth, and they wound up having all the classical signs of hemolysis and anemia, you know, like jaundice and splenomegaly and gallstones. Well, wait a minute. Why would somebody have splenomegaly with the hemolytic anemia? Well, if those cells are turning into blobs and they're dying a hell of a lot sooner than they should because of membrane defects, the only place they could go is to the spleen to get their final funeral, right? So that's why they have splenomegaly. But also remember another thing too. Even normal red cells can die at a quicker rate if the spleen is hyperactive for any other reason. Like we used the example of cirrhosis and portal hypertension yesterday, didn't we? There's nothing wrong with the red cells of somebody with cirrhosis, but the spleen is big and puffy and overactive because it's congested from portal hypertension, so it's chewing up the red cells and the white cells and the platelets faster than it should. Now, they get gallstones too, and I know we haven't done gallstones yet. You know, if you've seen gallstones in a lab, or you had gallstones, or, you know, your aunt brought back her gallstones in a bottle after her cholecystectomy, which they often do. And some of them were green, some of them were black, some of them were yellow. Well, you know, if they were yellow, it has to be cholesterol, right? What if they're green or black? What's the main component of a green or dark green or blackish gallstone? It's bilirubin, isn't it? So if a person with a hemolytic anemia, or in this case hereditary spherocytosis, gets a hemolysis and therefore jaundice, then that means elevated indirect bilirubin. And those are going to be bilirubin gallstones for the most part, aren't they? Okay, so let's move into another genetic situation. And this is also a very, very, very common genetic hemolytic anemia. And it's called G6PD, or glucose-6-phosphate dehydrogenase deficiency. Now, if you remember from biochemistry, something called a pentose phosphate pathway, well, that happens inside of a red cell, as well as other places chemically. And the enzyme called G6PD converts glucose-6-phosphate to 6-phosphoglutamate, or if you want to be more chemically correct, call it 6-phosphogluconate delta lactone. That's a necessary enzyme for that pathway. But let's say you have a genetic defect in which you don't have that enzyme, and therefore you can't do a good physiology in your red cell pentose phosphate pathway. Whoops, I'm sorry. I want to just make this bigger. Well, if that happens, the cell is no good. It dies before its time. It hemolyzes. And just out of curiosity, often hemolytic cells, due to any reason, don't look around. They look like maybe somebody took a bite out of them, or they go by various names. I know in the hematology lab, they'd probably call that a bite cell, because it looks like somebody took a bite out of it. But there's a lot of other names. Some of them might look a little bit wrinkly, but these are cells that are hemolyzed. So this is a hemolytic anemia too. And by the way, somewhere along the line, you're going to have to know that in some of the hemolytic anemias, and this is the classic one, by the way, so if some, joker on the step puts a picture of a Heinz body, H-E-I-N-Z body, it's probably going to be from glucose-6-phosphate dehydrogenase deficiency. It's been done before, and Heinz body is nothing more than denatured hemoglobin. And there's a way of staining that so the Heinz body comes out nicely. You're probably not going to be able to see it on a regular right stain, which this is. And it's going to look sort of greenish, sort of. And when the Heinz, when you have a G6PD deficiency, it puts your red cells more at a risk of oxidative damage, and that's why the cells are damaged. That's why the cells look bitten or fragmented. Now, without getting into the complex genetics, I think I just will tell you that there are several different types, because pathologists love to take simple concepts and then describe, 30 different varieties. The A- and Mediterranean type of glucose-6-phosphate deficiency are the most significant types. And there are types which are, almost subclinical or non-symptomatic as well. So much for G6PD deficiency. You know the biochemistry, you know what it might appear of if you look for the Heinz bodies. You know it's hemolytic, so the cells are going to look like maybe they're being chewed up before their time. In this case, it's recessive, and it's X-linked, okay? So only boys are getting it. It's not dominant like spherocytosis. And the thing to remember also is that for some reason which I have never been able to figure out, even though it's a genetic disease, it's very often triggered by fava beans. So if you've ever heard the term favism, they're probably talking about a G6PD deficiency, which the person that has it eats fava beans and then develops sort of kind of an acute hemolytic episode. Also know that there's a good number of drugs that cause it, and I don't think that every single drug that you prescribe is going to have on the package insert, well, be careful, this could cause a triggering of G6PD. But the ones that are really most likely are the anti-malarials. Now, I have the advantage of being able to zip up some of these pictures. Those are fava beans. I don't know, I feel that it's really wrong to talk about favism in a class if half the people there, including myself, have never seen what a fava bean looks like. Well, that's what a fava bean looks like. It looks like a lima bean, but it's a little bit browner and, I don't know, wrinklier, I guess. And have you ever had a fava bean, by the way? How are they? How do they taste?
Pretty good.
Really?
Yeah.
Like what? Like peas or lima beans or what?
It's like I would describe it kind of like stronger version of lentil.
Okay.
It has a strong smell.
Oh, you've had them too?
My mom forced me to eat it when I was a kid.
Okay, cool.
That was one of the things that I have to stay in.
You like them?
Now I do, but when I was a kid.
Okay. So, remember we saw those cells on the previous slide that were chewed up? When you see that, think, that's not a red cell that's going to wait to go to the spleen to get gobbled up and digested by macrophages. That's a cell that's being lysed in the blood vessels. And if cells are lysed intravascular, expect hemoglobinuria. Well, we already know there's going to be anemia, but also think of hemoglobinemia, hemoglobinuria. Now, this is another little thing. If you have a hemolytic anemia and you have increased amounts of hemoglobin in your blood, and it's not much, that may not go through into the urine. But in the severe hemolytic anemias, where there's a lot, and maybe even too much for the haptoglobin to keep up with, that free hemoglobin will go into your blood. Into your urine. So a hemoglobinuria, remember we talked about the common lab test? We never mentioned that one, did we? That's also a really, really good sign of a hemolytic anemia. Okay, let's talk about the mother of all genetic hemolytic diseases, and also the mother of all hemoglobinopathies. And a hemoglobinopathy is any disease which results in defective hemoglobin chemically, and they're usually all genetic. Sickle cell disease is the classical hemoglobinopathy. You know that normal hemoglobin A is heme, iron, and globin, and the globin is alpha 2, beta 2. And let's say theoretically you had a mutation or an absent gene in which, in the beta chain, you now substituted a valine rather than a glutamic acid. One single amino acid due to one single trinucleotide defect. That's all that it is. When you think that that globin is hundreds, it's just one. On the basis of that one, if it's heterozygous, you're going to have a little bit defective hemoglobin. And now it's going to be called hemoglobin S rather than hemoglobin A. So that is sickle hemoglobin. It's hemoglobin in which you have normal heme, you have normal iron, you have normal alpha chains, but the beta chains have a one wrong amino acid in the polypeptide sequence. It's pretty common. 8% of African Americans are heterozygous. So do the math. What's the chance of somebody being homozygous? You could see It's going to be way less than 8%, but it's enough to where, you know, you're going to have babies that are born with sickle cell disease. Okay? Now, because it is a homozygous, because it's a genetic disease that needs the homozygous state, in general, it's going to be expressed early, it's going to be expressed uniformly, and there's not going to be much variation to it, like in the heterozygous genetic diseases. So it may be apparent at birth that when the baby's blood is in the reduced hemoglobin state, non-oxygenated, you're going to see that because of that one simple little amino acid difference, a lot of those cells are going to not look round anymore. They're going to look like sickles. There's a sickle, there's a sickle. And don't forget, even though, if you've seen some of these, even in the babies that are severe sicklers, or we could say children or adults, that not all the cells are going to look like sickles. It might be, in this case, I think if you did a count and you used some judgment, you could say no more than a few % of those red cells are sickled. Well, that's all that it takes for these clinical and pathologic sequelae to occur. And one of them is, obviously, the big one, is hemolysis, isn't it? And because of the hemolyzing, it's going to be often a severe anemia, because those cells are releasing bilirubin. You're going to have jaundice of the indirect or unconjugated type. Because of that, those sickled cells in a more chronic situation are going to form little thrombi in the small vessels. And that's the basis for the pain. And definitely you're going to have little infarcts everywhere. But the place that is most obvious is the spleen. Because if you say a normal spleen is about like a normal kidney, 150 grams, or let's say 1/10 the size of a 1,500 gram normal liver, that eventually, I've seen a lot of spleens and sicklers, they're not 150 grams. They're not even half that size. A lot of them are not much bigger than a plum. You know, 1/10 the size. I've seen them like, you know, 10, 15, 20 grams often. And that relates to the chronicity of the process. Think about it. If you have a hemolytic anemia, your spleen should get big, shouldn't it? Because you're hemolyzing. That spleen now has to work. We already said that splenomegaly is a common feature of hemolytic diseases. So why am I now telling you that these people have extremely small spleens? Well, at the beginning of a sickle cell process, the spleens are big. They're hemolyzing. They're chewing up those damaged cells at a rapid rate. They're bigger than normal. They might be 2, 3, 4 times what a normal spleen should be. But with the presence of progressive microinfarcts, they eventually become very small. And the term autosplenectomy is also used here, meaning it's like if you have a spleen that's only 5% of what a spleen should be, for all practical purposes, you don't have a spleen. You autosplenectomize yourself. And also because they have a problem in handling bacteria. It has to do with size more than anything. If normally kids get a lot of H flu, you know, young kids less than 2, well, there's more than enough for sicklers. They love to get pneumococcal infections, and any bone infection in a sickle cell person is regarded as salmonella until proven otherwise. That's generally the spectrum of the disease. It is the mother of all hemoglobinopathies. What's this on the left? Well, you probably don't know what it is on the left or the right, but on the left is a spleen, and you don't know that this spleen weighs 300 or 400 grams, but you can see that it is a very hemorrhagic. There's a lot of red pulp, and on the right side there's a spleen that looks like it's mostly fibrous tissue, like it's been chronically infarcted. Well, this is the early stage of sickle cell. Well, you'll have hypersplenism, big spleen, and then finally, this is probably very close to the autosplenectomy stage. I'll give you another rule of thumb, by the way, for hemolysis and splenomegaly. We're going to get to the spleen eventually, but not so much here. Is that if you remember from your histology, you looked at a spleen, if you kind of remember what it looks like, even if you don't remember the names of all the cells, did you remember it's what they call the red pulp and the white pulp? And the red pulp was where the red cells go to die, and the white pulp are the lymphoid centers, and they literally are, you know, red and white when you cut through them. Now let me ask you this. Think of all the spleens you saw, maybe you cut in an anatomy lab, or even looked at under a microscope. What percent was red? What percent was white? What's the safest answer whenever somebody asks you a question like that? The safest answer is 50-50, right? Because it's the point at which you're least likely to be wrong. Well, it also happens to be the correct answer. So if you cut through the spleen, you're going to see a lot of those little white lymphoid areas. They'll be about 50% of the cross-sectional area, and half of it will be red, and also microscopically as well. Now, let me ask you the question. Look at the spleen on the left. How much white pulp is there? How much lymphoid cells are there? There's nothing. So that means that this spleen, I already told you it's big, but it's almost all red pulp. And it's all red pulp because it's the red part that has to work overtime, right? Okay, that was the little tip.
Is that because you're constantly sequestering your red blood cells that it's being like?
You know what? There's a lot of echo here. I'm sorry. I'm going to have to go up to you. I hope you don't mind that if I approach the bench. But I hate it when there's a good question, and your questions are usually good, and there's so much echo.
Is that because the red blood cells are sequestered so much there? Or is it because when you form sickle cells?
Did everybody hear her, by the way? She says it's because the red cells are sequestered, or is it because they're misshapen and they're being killed? And the answer is yes and yes. It's for both reasons. Okay. Most pathologists, even the ones that consider themselves real hematology jocks, which most of them do, they usually, when you mention the word thalassemia in front of them, they go like this. They cringe because there's so many types of thalassemia, and we all know it's a hemoglobinopathy because of either defective alpha or beta chain. So it's in the globin part, it's not in the heme part. And I'll be very honest with you. I, in my whole life, have never been able to understand the complex genetics behind all the thalassemias. It's something that, I'm sure the guy that wrote the book understands it at the time he wrote the chapter, but it's an amazingly complex genetics. So that's why I've taken the liberty over the last few years to summarize the important things and not throw the unbelievably complex stuff at you, because I don't believe in teaching something I don't understand myself, right? So let's talk about the thalassemias. Okay. It's a wide variety of hematologic, hemolytic diseases involving globin synthesis. That means we're talking about defective alpha or beta chains, right? The genetics is complex. Let's keep it at that. So if you have defective development because of a genetic reason of alpha or beta chains, it's going to probably wind up being some type of thalassemia. Now, we've already seen a genetic problem in one amino acid different from a single beta chain, but thalassemias are a lot more than that. Now, sometimes you'll hear the word thalassemia minor, sometimes you'll hear the word thalassemia major, and don't be spooked by it. All thalassemia major means it's probably going to be a type of thalassemia that will result in a very significant hemolytic process and a very significant disease. The thalassemia minors might even are either mild or minor in clinical severity, or they may be asymptomatic completely. So a minor person could very easily just be somebody that's carrying the trait and doesn't have the disease. The unifying clinical feature in all the thalassemias is that's a hemolytic anemia. And by the way, you might want to keep this in mind, because the most common type of anemia you'll be dealing with in all of your patients is a hypochromic, low MCHC, microcytic, low MCV, anemia called iron deficiency anemia. Well, guess what? The thalassemias are also hypochromic and microcytic. So keep that in mind. So not every anemia. So that would be like a great question. If I was sadistic enough to be forced to make a horrible board question, I'd say patient has a hypochromic microcytic anemia, but they have normal iron stores. What's the most likely diagnosis? Most likely diagnosis is some form of thalassemia. Now, it's hemolytic, right? And because it's hemolytic, that bone marrow has to work overtime, it has to expand, it has to be hyperplastic on the erythroid side. And take a look at this skull. And once again, I really hate to say, big time board, but I can't think of a single test where somebody did not show you a picture of an x-ray of a skull. And if they show you an x-ray of a skull, it's either going to be a bone that has kind of punched out lesions, and you're going to have to know this is multiple myeloma, or it's going to be something like this, in which the outer table looks like it's spiked. Do you see kind of like the spiculated or spiked appearance on the outside? You don't see little punched out holes, but take a look at that thickened spike-like outer table. Well, imagine that it's not really the bone that's spiked, but it's the stuff between the bone. It's the marrow. So if you have prominent marrow between bone spicules, it's going to make that normal, dense cortical bone look like it's spiked. So if you do get a board question on a skull, just flip a coin. If you don't have a coin in your pocket, just see if it's spiked, and then that's going to be thalassemia. See if it has punched out holes, and that'll be multiple myeloma. Let's take another type of hemoglobin disease. And remember, this is now alpha chains pathology. And it's going to be a hemoglobinopathy, like sickle was, like thalassemia was. And it's going to be called hemoglobin H. And I have no idea why somebody named it H, but I do know that H stands for high. So if you have a genetic defect in the production of hemoglobin, in which you have deletion of 3 alpha chain genes, you're going to have bad alpha chains, aren't you? And as a result, you're going to have a bad hemoglobin, aren't you? Well, the hemoglobin H has high affinity, so that's why I put that in big font. If you think hemoglobin H, think high affinity hemoglobin because of bad alpha chain genes. And let's say that you had a hemoglobin which just loved to suck in oxygen molecules. You're going to think, well, that's good. That means, he could probably live on Mount Everest and still suck in those oxygen molecules real good. Well, the problem is, they don't like to give them up once they have them. So even though it's really nice that they suck in oxygen real good, when they go to the tissues to deliver that oxygen, they don't give it out. It's an abnormal hemoglobin. And it's also unstable. So what happens if hemoglobin is unstable? It's a hemolytic anemia. Anything that makes the red cell unstable, whether it's membrane or whether it's heme or whether it's globin, is going to result in classical hemolytic behavior. And this is the example that I used of my dog Sandy, my golden retriever. My wife used to joke around about her. I throw the stick into the river like 100 times. She just loved to jump in there. She was like a duck with paws. and she would just love to get that stick. She had high affinity for doggy sticks in the water. But then when she came back, I'd say, baby, give it to me. And she wouldn't. So I said to my wife, well, why doesn't she just give it to me? She loves me. And my wife says, well, you know, she's a retriever. She's not a releaser. So that's what I think of when I think of high affinity hemoglobin. Okay, where have we heard this before? We've heard this before, hydrops fetalis, when we talked about RH sensitization. This is when your question is going to be answered now. We said that the RH antigen, big D on the baby cells, if the mother's been sensitized about the hemoglobin, blah, blah. Well, let's say the baby cells are hemolyzing for other reasons. So not all of hydrops fetalis is RH associated with. Let's say the baby has a genetic defect involving 4 alpha chain genes. Remember, the other one was 3, and that was pretty severe? Well, look at this one's 4. That's even more severe. In fact, it's so severe, most of these babies are never born alive. And guess what? This is not just a little postage stamp I put on here. I was actually able to keep the intensity of the picture. Is this like the other one we saw? A lot of edema, especially around the neck. Remember, we call these cystic hydroma. This is massive edema. And why is there edema? Well, for the same reason there was massive edema in the RH baby. It's because there was massive hemolysis. The heart had to work massively hard to deliver what little oxygen it could because most of the hemoglobin was bad, and the heart failed. And when the heart fails, you get edema. It's a simple anatomical concept. So this is the most severe form of thalassemia. Most of the babies you see like this, they're never born. And I guess I would like to insert the phrase, well, you know, thank God they're never born. But that would be sort of like a religious statement, and I don't like to get involved with those kinds of discussions. They have very severe hemolytic anemias, just like in erythroblastosis fetalis. And they have all the classical signs, if they are born, of a severe, severe anemia. They have pallor, like all, they have jaundice, they have Kern icterus. By the way, do you remember we said that Kern icterus was bilirubin staining areas of the brain like the basal ganglia and the thalamus? We also said that unconjugated bilirubin is less water soluble than conjugated bilirubin, right? Well, what is the brain? The brain is fat, the brain is myelin, isn't it? So it would be almost unheard of for a conjugated bilirubin to stain the basal ganglia, because that's more water soluble. The bilirubin of hemolytic anemias is more fat soluble. And massive hepatosplenomegaly in the hydrops babies too. So, you know, even the radiologists can tell this. They say, like, you know, that baby has a liver 3 times, or that fetus has a liver 3 times what it should be. There's big abdominal bloating. You see it's all liver and spleen. Why? Because there's hemolysis. And the hemolysis is not only going on in the spleen, but it's also going on in the liver. It's going on everywhere. Okay, you know what? Let's see, do we have a logical break here or not? Yeah, we have a logical break. So it's about 10:30 here. Let's take a 10-minute break. I'm going to run to the men's room, and then we'll finish the next hour. And I could go faster, we could speed things up, but I feel very comfortable at this pace. What do you think? How many vote for speeding me up? How many vote for staying the way I am? Okay, I'm hearing it. I'm hearing it. See you in 10 minutes, folks.
You must remember this, a kiss is still a kiss, a sigh is just a sigh. The fundamental things apply as time goes by. And when two lovers woo, they still say I love you. On that you can rely.
Did everybody online hear me okay in the first half?
What the future brings.
Thank you for the correct answer. I was hoping for that.
Moonlight and love songs never out of date. Hearts full of passion, jealousy and hate. Woman needs man, and man must have his mate. That no one can deny. It's still the same old story, a fight for love and glory, a case of do or die. The world will always welcome love as time goes by. It's still the same old story, a fight for love and glory, a case of do or die. The world will always welcome lovers as time goes by.
This is our kind of song.
You're showing different images for Heinz bodies here. This is what I typically think of as the gas part. Okay, kind of this hypnotic.
Yeah.
So,
There's just one thing,
but
you
they're
see,
stained of
we never ever do nothing.
so
crackle
Nice.
inside.
and this is something like what you were showing. How is that a Heinz body? Because it has no little.
No. The Heinz body is not.
We're gonna take the
device.
beginning of this
That
song
just
and do it
refers to the fact that there's a
easy.
defect in the sound.
But then you're
And
gonna
this
do the
also
finish.
looks like it's in a Heinz body state. It looks like
Really
it's
deep
okay.
down.
So if they were going to find a Heinz body, there'd be one there.
Nobody would ever show you a Heinz body
Like that.
with the right stain. They would always show it to you in one of those special
Listen to the story.
Okay. And what about?
Even though there's a few other things in there, it's always at the top of the list. That's a classical thing.
Yeah, this is stained with a different stain.
Yeah.
So what would that be?
Well, they're high bodies. Denatured hemoglobin.
But what kind of stain is it?
I don't know. Heinz bodies. No, not Prussian blue. Because Russian blue that's not iron.
Now this one really confused the heck out of me.
That's pretty severe. It would. I've never seen one like that. But there's generally junk
Would you
in
say?
it.
Would you say the darker images would be the Heinz body?
Yeah, absolutely. Probably all those little. This is just severe Heinz body thing. Probably the one that I showed you would be the most likely.
Oh yeah. What's that the one?
rolling,
Rolling on the river.
rolling on the
Was on the desk. Okay, well, that was the end of the third song, and you know what that means. It means we're going to get dirty again and finish the second hour of the second day of the discussion on diseases of red blood cells. Let's just make a little announcement in terms of getting our balance again. I'm going to have plenty of time to finish this chapter. And for those of you who are fans of the updated M drive, if you looked at the 3 chapters that will be on the next test, there's going to be about 15 to 20 yellow slides on each one. I updated it recently, like maybe last night or early this morning, so those are the things that we will cover in the review, which will follow the discussion, which means we have to be done with this in another day and a half. So this is the general plan, the way I see it. We're going to do a lot more stuff on hemolytic today, and maybe even do the anemias of impaired production, who knows. But tomorrow, which is Wednesday, which is, I think it's going to be Pearl Harbor Day, we're going to finish up probably the entire discussion. Now, Dr. Jalan told me that when he had the discussion on hemodynamics with you, you covered the topic of coagulation disorders. Now, I know there's a coagulation discussion on hemodynamic, and there's a coagulation discussion on red cell. He reassured me that all of the material that is in this chapter for coagulation, he's already gone over with you. I might do a quick flash just to see if it sounds familiar. I don't plan on doing a lot of coagulation. I just may zip through it just to verify that he is telling the truth, which I'm sure he is. And then after that, we'll do our review on Thursday, even if it's in the second hour. And then you're going to be in really, really good shape for the exam. I expect everybody here to ace my exam. I don't mean ace it. I mean get everything right. Everything, okay? Otherwise, I'm going to personally have very, very hurt feelings if every person here doesn't get every question perfectly correct. That's going to be mostly because of our great review beforehand.
Are you taking the entire exam, or is it all?
I guess so, because all of it is on material I gave, right? It's going to be on, we already did infectious, so it's going to be on peds, it's going to be on immuno, and it's going to be on RBCs, right? 3 chapters, 15 to 20 questions for each one. I'll do the whole thing. And, you know, I know, as long as we're talking about exams, which I hate to talk about, but, you know, I don't believe in exams that beat around the bush, you know, like if a train leaves Chicago at 50 miles an hour. I believe in the type of material that will absolutely reinforce your core knowledge. And then once that's been reinforced, I expect you to use that when it comes to the real integrative type exam called the board. Okay. The last thing I want to do in my life is to imitate one of those wimpy ass people that make up board questions. I want to make my questions in such a way that you really, really understand the important things. And those important points we'll be reviewing before the exam as well. So let's continue on with our journey, our trek through hemolytic anemias. And now, let's talk about another disease that produces hemolysis. Well, once again, either I'm deaf or there's too much echo, so I'm going to approach the bench. No, the yellow slides that are there right now on your undergrad are written in stone. There's going to be no more changes. But as long as you brought it up, I hope you all know, you know, I know a lot of people don't come to class. That's fine with me. I'm thinking maybe they watch the movies, whatnot. But I know what exam junkies you are. It's our fault. We have turned you into exam junkies, okay? That's your constant fear. The people that live only to pass exams know they can do well by looking at yellow slides. So forget about all those other ones. Well, can I tell you something? That's not the way the board operates. So I expect you to sort of know everything, but I'm going to emphasize the important points. So, you know, there are a lot of people that like to take the easy way out, and they think, well, let's just do the yellow slides and do well on the exam. And, you know, those are the people that are going to really, really mess up badly on the step. You know that. So let's just say I believe everything that comes out of my mouth is important. Otherwise, I wouldn't be opening my mouth. But in terms of items for examination, I believe that we should focus in very clearly for you what the important points are. Okay, let's say that you had a defect in your red cell membrane. And it's not a genetic defect, but it's an acquired, it's not an inherited genetic defect, it's an acquired genetic defect, something that gets mutated before or after you're born, okay? And let's say you have your normal bilipid layer here of your red blood cell. And let's say that there's something on the surface of that called GPI. And it's not simple, it's sort of a linked protein. A lot of people say that GPI protein acts as lipid rafts, something that'll move lipid substances in and out nicely. Otherwise, you know, you have that nice bilipid layer, you know, between the two aqueous layers and your cell membrane. And let's say that this structure, it looks like a mushroom to me, but we'll call it GPI. It's called glycosyl phosphatidyl inositol, and that's why it's called GPI. Well, let's say that this structure has a critically important gene for it to be formed, and that gene is called PIGA. Now, if I had a hard time pronouncing glycosylphosphatidylinositol rather than GPI, the PIGA is going to be even worse, okay? But bear with me. The PIGA gene encodes for the PIGA enzyme, which enables GPI to be on that cell membrane. And the PIGA gene is called PIGA and the enzyme is also called PIGA because it stands for phosphatidylinositol N acetylglucosaminotransferase subunit A. Whew. That's PIGA. Now you know why they call it PIGA. Okay, and that enzyme and that gene is necessary for this thing to be here, for the membrane to function properly as a lipid raft, okay? So, but if you have a mutation, an acquired mutation of that gene, okay, you're going to have a defect in the membrane. And what happens if there's a defect in the red cell membrane? It makes it more susceptible to not living too long, right? So it's a hemolytic anemia. Now, I've been skirting around the actual name for this disease. It's called paroxysmal nocturnal hemoglobinuria, also known as PNH. And even though you may never heard of it, let me tell you, it's pretty common. You know, it's one of the big topics in hematology. And the reason why I hate the term is because you know what paroxysmal means. It means that it occurs as like a convulsion, just like suddenly, and paroxysms, and earthquakes. And nocturnal means it occurs at night. Well, the problem is, ladies and gentlemen, when you actually look at the statistics of the patients who have these gene defects and the PGI defects and then the hemolytic anemia, it's paroxysmal and nocturnal only 25% of the time. That's a misnomer, but probably the first few patients that was described in, so unfortunately the name has to stay the same. So what do you want to take home about this type of hemolytic anemia involving a membrane defect? Well, you have to know that the defective product is GPI on the membrane. You have to know the defective gene and enzyme or PIGA, and you have to know, because of that, it winds up being a hemolytic process. And you have to know that's called paroxysmal nocturnal hemoglobinuria. Now, why would it be called hemoglobinuria? Well, because if that red cell membrane is now unstable and it's hemolytic, there's probably a lot of hemoglobin that goes into the serum, right? And what happens when there's a lot of hemoglobin, paroxysmally perhaps, going into the serum? Well, it's going to go into the urine then too, isn't it? So that's why it's called PNH. And let's move on. We've already touched on this topic in several different ways from previous chapters, but let's talk about the so-called immunohemolytic anemias. And do you remember when we talked about autoimmune diseases, we said AHA, autoimmune hemolytic anemia? Well, it leads you to believe that we have antibodies which can coat our own surfaces of our cells as an autoimmune phenomenon and cause hemolysis. The reason why a better name for this is not AHA, which is the older name, but immunohemolytic anemia, is not all of it is autoimmune. Some of it is due to sensitization of the cells by certain drugs. And I'll probably give you a list of those somewhere along the line. But let's say we have the concept now of our own red cells having our own antibodies on the surface, whether it's purely autoimmune or whether those cell membranes have been damaged by drugs or viruses, okay? Or even bacteria. Well, there's three different kinds of antibodies that could be on those cell surfaces. You could have warm autoantibodies, and that's IgG. And why is it called warm? Because it's only present when it's inside of our body temperature. Once that blood is drawn and you put on a test tube in the hematology lab, it doesn't cause agglutination. It only causes agglutination what's in the body. Now, on the other hand, let's say you have cold agglutinins, and those are of the IgM class, usually. Well, cold agglutinins means the red cells have the bridging IgM autoantibodies against them. And guess what? They'll cause agglutination even after you draw that patient's blood. And you put it in your little test tube, put it in the rack in the hematology lab. It's cold, right? It's no longer room temperature. That's why they're called cold agglutinins. Now, as you might guess, we also have the concept of a cold hemolysin as well. Now, what's the difference between a agglutinin and a hemolysin? Well, for those of you that have ever done blood typing, you know that all agglutinins have to do is agglutinate red cells, bring them together, okay? But a hemolysin is an antibody that fixes complement and lyses the cell membrane. So it's a big difference between bringing a bunch of red cells together and causing them to agglutinate and bringing some red cells into ruin by having antibodies coat the surface that lyse them. And those are usually IgG antibodies. Okay, and once again, they use the word paroxysmal, which means it happens sort of suddenly. So, and I also made the note down there that if you hear somebody use the word autohemolytic anemia or autoimmune hemolytic anemia, be a little forgiving for them, because most of these are autoimmune. But I'm going to show you now some of the ones that aren't, okay? Well, one of the common drugs that will sensitize red cells to have antibodies, patients are the antibiotics. And I bet you that there is a list. I bet you your pharmacology prof probably can rattle off 20 things, but I'm just going to rattle off the 3 most common. And some of these I have barely even heard of. Cefotetin, I hope if I'm mispronouncing it, forgive me. Ceftriaxone and piperacillin. These are common antibiotics or antimicrobials that'll do it. Now, when we said that the warm agglutinins will not hemolyze at room temperature, but only inside the body, the most common situation for that would be a patient that is primary and idiopathic. That's autoimmune disease, isn't it? But there's a wide variety of patients with tumors, especially leukemias and lymphomas, as well as some drug situations that this will happen. Now, many drugs can sensitize red blood cell membranes to invite the presence of warm agglutinins or agglutination going on inside the body. If you have a patient with mycoplasma pneumonia and you draw their blood and then you put that little blood tube, off to the side for a second. Normally it tends to settle, of course, even if you don't spin it down for a hematocrit. But in patients with mycoplasma pneumonia, often, which is a bacterial infection, or HIV, which is a viral infection, or mononucleosis, EB virus, you will often see that blood agglutinate. And those are cold agglutinins, and they're usually IgM. But now, let's say that they lyse at room temperature. They don't just agglutinate. Well, that's a situation in which you have IgM fixing complement, and that occurs often in mycoplasma as well. Now think about it. If it's lysing, do you think that might result in hemoglobinuria? Absolutely. Because a lyse cell will release free hemoglobin into the serum. If it's significant enough, will result in that hemoglobin going into the urine as well. So that's the general classification for the immunohemolytic anemias. And really, what you really have to know is the difference between a agglutinin, a hemolysin. You have to know the difference between warm and cold. You have to know the difference between an IgM and an IgG. And you have to know that many drugs cause this, and I've already given you a couple of bugs that do as well. Mycoplasma pneumoniae, HIV, and mono, or the EB virus. Did you ever hear of a Coombs test? Good. I'm glad somebody has. When you suspect a patient has a autoimmune or any type of hemolytic anemia, this test is ordered in all hemolytic anemias because you have to ask yourself, are those cells hemolyzing because of antibodies on the surface? So they do a Coombs test. And there's two kinds of Coombs test, Coombs. And one of them is to take the patient's blood cells and just to see if there's some surface antibodies on the surface of that cell. And one way to do it is to make an antibody against an antibody and see if it lights up, if you're using a fluorescent technique. So that's the direct Coombs test, is when you're looking to see if the patient's cells have antibodies. Now, the indirect Coombs test is like a backward blood typing. You're not looking at the cells, you're looking at his serum. So in an indirect Coombs test, you're testing the patient's serum for antibodies, which could theoretically react against the cells. Now, whether his own cells have those antibodies on them doesn't really matter. You're just seeing if he has antibodies which characteristically can coat the surface of cells against red cell antigens. So you should remember that. And when you work up your patients with anemias, and because it would seem like almost all the anemias so far that we talked about are hemolytic anemias. It's just a standard part of every hemolytic anemia workup. Okay. Yes?
Can you apply that in context of, I swear you're going to in the context of maternal blood versus antibody versus baby's antibody in RH incompatibility?
Okay.
In the context? So I always get confused in the concept. Like, testing
Coombs test?
Yes.
Well, that's an interesting thing. Let me think about that for a second. You're talking about the role of a Coombs test in a maternal fetal incompatibility, right? Well, if the baby's and mother's cells are typed properly in serum, and you have a hemolytic anemia in a baby, you show that's against anti-big D usually, which it usually is 95% of the time. You're saying, is there still a role for a Coombs test over there, right? And I don't know. I think if you can determine the specific antibody and show that it's direct against a specific antigen, even as not from the same person, I don't think you'd have to go any further than that. Okay, we're nearing the end of our journey on hemolytic anemias, and we propose a lot of genetic and other reasons why red cells are more susceptible, hemoglobinopathies. Let's think of something very, very common now. Let's think of mechanical breakage of blood cells. Normal blood cells, there's no antibodies on them. They have normal hemoglobin, they have normal heme, they have normal membranes, they have no genetic defects. But they're being chopped up, they're being chewed up, not by organisms, but think of the possibility of an artificial heart valve. Some of them are grafts from other species, some of them are mechanical valves, some of them have metal in them. So it is not uncommon to look at a patient's blood who has a mechanical heart valve and see more than just a couple of red cells that look like they've been bitten or chewed up. And if you want to call them a bite cell, or you want to call them by whatever they look like, sometimes they're called cigar cells. There's a whole bunch of names, and I don't want to confuse you with them because none of them are really specific for anything. But if they look like they've been fragmented, they're not perfectly round, then that would be one reason for a hemolytic anemia, simply because of mechanical factors. But let's take another situation in which you don't have a mechanical factor chewing up red cells. Let's take a case of fibrin itself plugging up small blood vessels, capillaries, and on the basis of that, those red cells cannot get through easily, and they're likely to fragment simply because that the small pipe called a capillary, which they have to go through, is now partly obstructed. So you've probably seen movies of red cells, squeezing through. They could really do a pretty good act there. But let's say that the hole is just too damn small. They can frequently fragment because of that. And those are called microangiopathies, okay? They're diseases of small blood vessels. They may be due to platelets or some thrombotic disorder clogging up the veins. They may be due to defects in the blood vessels themselves, causing abnormally small calibers. And I threw a couple of words on there, and they're really the same. Because Dr. Jolan assured me you talked about coagulation disorders, I'm assuming you have heard of the concept of TTP before, thrombotic thrombocytopenic purpura. Well, the reason why you have thrombocytopenia is because your platelets are aggregating in the small blood vessels. And because of that, you have a thrombocytopenia. They're consuming them. That's what they call a consumptive coagulopathy. Related to that very strongly, and some people will even say it's probably the same disease because they're so intimately related, is another disease called hemolytic uremic syndrome. And in hemolytic uremic syndrome, well, you have a patient that's hemolyzing, right? And then all of a sudden, they go into renal failure. And they go into renal failure because in the process of intravascular hemolysis, they're setting up these little clots all over the body. And so, if you have a bunch of little clots inside your muscle, well, so what? Well, let's say they're inside your glomerular capillaries. That could be significant enough to actually go into an acute renal failure kind of a picture. Okay, guess what? We're completely done with the concepts of hemolytic anemias, and that was the biggest chunk of anemia, believe me. Because even though I made a list here of about 7 or 8 non-hemolytic anemias, in other words, anemias of decreased production, they can really kind of lump them into about 3 or 4 categories. And the common ones are always iron deficiency, B12 and folate deficiency. Sometimes these B12 and folate things get the word pernicious anemias, even though they're not exactly the same. Sometimes they're called megaloblastic because in the B12 and folate are pernicious anemias. The cells, the red cell precursors in the bone marrow are way, way, way bigger than they should be. So that's why they're called megaloblasts. And remember, that's different from macrocytes, isn't it? A megaloblast is a nucleated red blood cell in which the nucleus is much, much, much larger than it should be. Whereas a macrocyte is an anucleated cell in the peripheral blood that just happens to have a MCV greater than 94. But usually the macrocytic anemias are more than 94. Usually they're into the hundreds, okay? Iron deficiency anemia, also an anemia involving the production of red cells. Why? No iron. Iron stores are gone. Anemias of chronic disease is a big wastebasket category. It's not a specific disease, but I think it would be fair to tell you that when you get really, really, really sick patients and they have either significant vital organ failure or multi-organ failure, it's very, very likely they'll be anemic. And there are certain patterns you see with liver failure. There are certain patterns you see with renal failure. But generally, it's a wastebasket category. So let's say this. Anybody with significant chronic vital organ failure is much, much more likely to have an anemia, and that's called the anemia of chronic disease. And that includes people with malignancies as well. Then we're going to talk about the concept of aplastic anemia, and as you might guess, an aplastic anemia is anemia because the stem cells, which eventually differentiate to form all the lymphoid or all of the other types of cells, there's some problem with them, or they can be purely in the basis of the red cell line rather than the big stem cells that'll give rise to the lymphoids and all the other cells. And then I don't know, we're probably going to mention something briefly about other forms of marrow failure, but I really can't remember what that is right now. So let's talk about, now that we have in general the concept of anemias of decreased production, let's summarize it by saying an anemia of decreased production is an anemia not in which the cells are dying before their time, but they're having a hard time being produced quickly enough and in enough numbers. And that's the big difference. And as you would guess, probably in most of these anemias, you would not have an erythroid hyperplasia. Why? Because once these red cells are made, they're not necessarily going to die faster. They just have a harder time being produced. And remember, an erythroid hyperplasia often is due to, will show the marrow to be hyperplastic because of the reactive erythroid hyperplasia. Well, in a lot of these, the marrow is hypoplastic, with one big exception, okay? So let's go into a few of these one by one, and maybe we'll get most of them done today. I think it's probably appropriate that we talk about the megaloblastic anemias first, because it's the anemia, the megaloblastic anemias you can all probably diagnose very easily by just looking at a peripheral smear, because not only are the erythroid precursors bigger than normal in their nuclear and cytoplasmic size, but this is also reflected into the actual size of the corpuscles, the anucleated cells as well, and they all look big. And if you don't want to go to the lab to look at the slide, then just look at the MCV number on your printout. It's going to be greater than 94. In fact, if it was only 95 or 96, I'd probably ignore it. Almost all of them are going to be like probably greater than 100. So, almost all megaloblastic anemias will produce macrocytes, and almost all, or we'll say all, have something to do with impaired DNA synthesis. And we'll also go a step further and say that one of the things that is likely missing in that person to produce the proper DNA synthesis is vitamin B12 or folate. So do you want to say the megaloblastic anemias are generally anemias of B12 or folate deficiency? Yeah, I guess you could say that. In fact, I can't think of a single anemia that's ever been worked up by a physician in which he didn't order a serum B12 and folate level. And if he sees quickly that there is a high MCV or macrocytosis, well, most likely he's going to do that as a knee-jerk reflex, because he's going to know almost all of the macrocytic anemias are megaloblastic, which means B12 or folate. And this is the part that is not logical, and I wish I could tell you the answer, but I told you that in the hemolytic anemias, you all see erythroid hyperplasia, but the opposite may very well be the case with the non-hemolytic ones. But for some reason, the bone marrow in these not only has big, nucleated, irregular, often bizarre erythroid precursors, but they're also hyperplastic as well. And to make things a little bit more complicated is that even though we're talking about anemias, which means red cell, which means erythroid precursors, what if I also told you that in this disease, even the myeloid precursors are often big? You have big bands, big metamyelocytes, you know, big myeloid precursors as well. So they can have a hyperplastic or hypercellular marrow. But here's a good question. Well, they have a hyperplastic or hypercellular marrow. So we know that this marrow cellularity now is going to be more than 50%, right? Because that's a definition of hypercellular marrow. But what do you think the ME ratio is going to be? If it's hypercellular or hyperplastic, but most of those cells are erythroid precursors, then the ME ratio, once again, is going to be low, isn't it? Because there's more erythroids than myeloids. It's probably not going to be 3 to 1. It could be theoretically 1 to 3. That's pretty low. Now, this is the part that you're going to go crazy when you see, because it's not going to make sense. But then we're going to go back to one simple thing about B12 physiology, and it's all going to make sense. So if you were the type of person that likes to memorize things, and I'm not, I like things to make sense logically. If somebody was to get you on a good day right when you study for the test, and they say, oh, give me about 13 things that cause megaloblastic anemias, well, you say, well, maybe if you don't have enough B12 or folate in your diet, maybe you're a vegetarian, so you're not getting much meat, you know, and a lot of that stuff is in meat. Let's say that you're not you get the vitamin, but you're not absorbing it. You know, let's say that you, for some reason, either genetic or otherwise, you don't have a lot of intrinsic factor in your gastric mucosa, and therefore you can't absorb B12, and therefore you got a megaloblastic anemia. Let's say that you had a large part of your stomach cut out from surgery, so you don't have much gastric mucosa and intrinsic factor left. Let's say that you have a malabsorption disease of the small bowel. Let's say you have inflammatory bowel disease or sprue or something that just generally interferes with proper intestinal absorption. That would be another reason. Hey, maybe you have an intestinal disease like scleroderma, you know, causing sclerosis of your small bowel, or a lymphoma involving the small bowel. Let's say that you had a large portion of your small bowel cut out, an ileal resection. What if I told you that all of the B12 is absorbed, not in the small bowel in general, but mostly the ileum, and mostly the terminal ileum? Let's say that you had a fish tapeworm infection. Do you remember that guy that we called Diphyllobothrium latum, the fish tapeworm? Let's say that you got one of those guys, and for some reason, he needs those vitamins a hell of a lot more than you do, so he winds up taking them out of your GI tract before they're even absorbed, and therefore you have an absence of them that way. Let's say that you have something called a blind loop or diverticula of the bowel, in which you have an area of your bowel that is not passing food or feces or liquids through very well, and therefore they're being overgrown with bacteria. What if I told you that that bacteria really loved that vitamin too, not just you, and it was taking away from you? That's another reason. Let's just say that everything is going fine, but you just need more of the vitamin. Well, one reason why women need a lot more vitamins than men is because they get pregnant. So they need an increased amount of, let's say, B12 or folate, especially folate. Other things like, which I can't explain very well, we explain pregnancy, but hyperthyroidism and disseminated cancer. So isn't that a lot better than just memorizing the list? But the best way to think about it is just to go back to regular old vitamin B12 physiology and say, look, you get the vitamin. It's in meats, it's in vegetables. It combines with intrinsic factor, which is a protein made in your gastric mucosa. So let's say you have a normal gastric mucosa and you don't have antibodies against it, or let's say you don't have gastritis, you know, from drinking too much or having, you know, too many hot foods. Then, once the intrinsic factor combines with vitamin B12, it passes on through and gets absorbed in the terminal ileum. But let's say there's terminal ileal disease, you know, some of these things like blind loop or malabsorption disease. So, here is the bottom line. You get the vitamin orally, it combines with intrinsic factor and gastric mucosa absorbed in terminal ileum. Defects at any of these stages can produce a megaloblastic anemia. And look, isn't that better than just rattling off, you know, 15 or 16 things like this without knowing why? So I would much, much prefer you understand this than this, because I could tell you, most people, when you give them a list like this and it doesn't make sense, they only remember the first 2 or 3 and then they forget everything else. That's just human nature. So here's something to remember big time again. All megaloblastic anemias are also macrocytic. So if the upper range of your MCV was 94, someplace will be 92 or 95 or 93, but let's say 94. That when you see MCVs of 96, 97, you know, you're not going to get too alarmed. But when they get over 100, you're going to say, this person has macrocytosis, and maybe that macrocytosis is on the basis of a megaloblastic process in the bone marrow. Now I know what you're thinking. You're thinking, well, maybe you can have macrocytosis without having megaloblastic changes in your marrow. And the answer to that is hell yes. I could probably think of 3 or 4 more reasons why you can have red cells that are bigger than normal but not have a megaloblastic anemia. But let's forget about those for now. So, you got a patient that has a macrocytosis. You could see it, you could measure it. You got a bone marrow now that is generally hyperplastic, hypercellular, and has a low ME ratio, so most of those cells are erythroblasts, and a lot of them are big, horrible looking, I was almost going to use the word malignant, but they are very atypical, but they also have big neutrophilic precursors as well. There was a very famous hematopathologist I worked with in Chicago. His name was Hilliard Cohen. He's gone now, but he happened to be the uncle of Mama Cass. That's the one thing I remember about him. And we'd be looking at bone marrows together, and we were looking at bone marrows, and I said to him, we're looking at a bone marrow of a person with megaloblastic anemia. And I said, well, isn't this bone marrow like, you know, the 40s, the 1940s? And he said, why is that? I said, well, because they have big bands. So in other words, even the precursors to the white cells, the granulocytes, are big bands, big metamyelocytes. And, are you ready for the punchline? We've said this before, is that not only are the mature granulocytes now being derived from big bands and big metamyelocytes, but guess what? They're also hypersegmented. So if you remember when I told you yesterday that the average number of segments per granulocyte is 3.4, you know, and let's say you had a machine that could count 1 million of them, and they come out with the average at 3.4. Well, what if that same machine counts 1 million of the granulocytes in somebody with a megaloblastic anemia? It might be 4.4, it might be 5.4. Sometimes when you look at these hypersegmented neutrophils, you know, because you happen to be, you know, nothing else to do in the hematology lab that day, sometimes you'll see them at 8 or 9 segments, individually different segments connected by little strings. So these are the laboratory features of megaloblastic anemias. Now, how does the word pernicious come into it? Well, pernicious is a historical word. I think pernicious is basically some kind of word that means bad, because, you know, diseases are bad. So I don't know why it's called pernicious, but the original pernicious anemia had all of these features, and that's why I'm defining it. And there are things that would make you believe that the original pernicious anemias pertained more strictly to vitamin B12 rather than folate. So, let's take a pernicious anemia patient. They have megaloblasts in their bone marrow. They have may have leukopenia, but the granulocytes are hypersegmented. Now here's the part you're not going to understand, because I don't understand it either, but very often they're jaundiced as well. So the pallor of their anemia is often masked by the jaundice of the bilirubin. Now I know what you're thinking. You're thinking, well, wait a minute, they can't be jaundiced because you're telling us that these are anemias of decreased production rather than anemias of increased destruction. So how could they have jaundice if they're not showing an increased destruction of their cells? Well, the problem is, in this case, they are. So pernicious anemia is the notable exception to the rule that many of the non-hemolytic anemias are not hemolytic. And it's also an exception to the rule that most of the non-hemolytic anemias are hypocellular, because in this case it's hypercellular. Achlorhydria, well, why is that? Why should they have decreased stomach acid? What if I was to tell you that if you had an autoimmune disease in which you're making antibodies against your own intrinsic factor, what if I told you that it's frequently associated with antibodies against your own parietal cells as well? So you take a person with pernicious anemia, now you could see in this classical thing, it looks like an autoimmune disease. They don't have one product of gastric mucosal epithelium called acid, and they don't have another product of gastric mucosal epithelium called intrinsic factor. So they go hand in hand. So somebody that doesn't have a high, or doesn't have a low pH in their stomach acid could very well develop pernicious anemia as well. Now obviously, they can't absorb B12. Why? Because they don't have the intrinsic factor to get down to that terminal ileum to absorb it, because it never combines. Another reason is that they'll have a low serum B12 level, won't they? So that's why, in most cases of macrocytic anemias, you're going to order that B12 and folate levels. In fact, I could probably give you a list. You may very well go to a hospital which, if you're admitting a patient with anemia, they're going to have some little thing put on a list that the government made up for you, or the medical staff, let's say, in which you're going to order these 5 things for every anemia. You're going to order a haptoglobin, you're going to order a Coombs test, you're going to order a serum B12 and folate level, you're going to order a serum ferritin, which we'll talk about later, to see if there's iron deficiency. These are just a general battery of tests. We call them shotgun therapy. I call them no-brainer things because they're things that are determined you have to order rather than think about them. And if I didn't want you to think about them, I wouldn't be teaching them. Another thing that pernicious anemia patients do is they flunk the Schilling test. And I did many, many Schilling's tests because I spent a couple of years in nuclear medicine. I got my boards in nuclear medicine. We did the Schilling test a lot. It's a very simple concept. Let's say that you gave a patient vitamin B12 by mouth, and that vitamin B12 happened to have a little isotope attached to it. Well, if he's normal, it's going to go to his stomach, it's going to be combined with the intrinsic factor, it's going to go down to the terminal ileum, it's going to be absorbed, and then it's going to go into the blood, and guess what? A certain amount of that will go into the urine as well, won't it? What happens if he has pernicious anemia? And you give him that radioactive tracer. Well, he doesn't have intrinsic factor, does he? So it'll never get absorbed, it'll never get into the blood, and it'll never get into the urine. So let's just say there's a certain amount of radioactivity that you expect in the urine a day or two after you give somebody a radioactive B12. But if he has pernicious anemia, intrinsic factor failure, possibly even due to autoantibodies, we'll call this an autoimmune disease, won't we? Then he's not going to have any radioactivity in the urine. Okay.
Dr. Narcisse?
Yes.
So from what you said, that shotgun, was
Well,
What would be your step of working through anemia?
well, I'm sitting here for the last 2 days talking to you about anemias and trying to explain the processes that are going on and differentiating between various types. And that means that in the process of learning that, you're thinking, okay, now let's say that I said to you, oh, by the way, you know, you got your MD degree now. You don't have to think anymore because now we have what we call hospital templates or hospital protocols. So very often, like patients that come in with chest pain, for example, you could be the world's best cardiologist, you could know EKGs up and down, you could understand everything about lab, everything about cath, everything about nuclear. But let's say that your hospital policy is for every patient that comes in with chest pain to get boom, 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 boom. That's what I call shotgun therapy. Now, is it good? Well, it might be good legally, because if you're ever sued, you could at least say you followed the standard of care by having all these tests done, because that's the standard of care at your hospital. But what I think it also does is it takes away your freedom to think about what should I order. See, I'm teaching you these last couple days, what should I order? Well, let's say you're on the staff, or let's say there's a new government rule saying, oh, by the way, Medicare is not going to reimburse for Schilling's test anymore. Well, it doesn't matter if you understand the principle of Schilling's test. You're just not going to be able to order it for your patients, are you?
But how would can you just work through like a case or something for a lab, like how you would work it up? That's
Well,
what I want to learn, how you would.
How I would do it? Well, even after I just bad-mouthed it for the last 5 minutes, I would probably do the same thing. You want to know why? Because, you know, every time I get into my car, you know, in which my life is at stake, you know, I look in the rearview mirror. I make sure that, you know, there's no flat tires. You go through a little routine, like a checklist, when you are taking off in your private plane. You know, that's a thing that you have to do. If you didn't go through all of that, you might get a little sloppy and forget things. So I think to a certain degree, these little rubber stamp templates are probably good. I'd probably wind up doing the same thing. But remember, a lot of those are going to be wasteful as well.
Because right now, all the HMO and PPOs, they're saying that we order too much tests.
That's
So
what they're saying.
When I was working in ER, they're cutting all these tests.
Mm-hmm.
So that's why I'm trying to learn from you right now how to best
managed care.
How to best order the test to get it.
Managed care, Obamacare, third-party payers, HMOs, the only thing they care about is money, is reducing their overhead. But if you don't order a lot of those unnecessary tests, let me tell you, because everybody I know this has happened to, they're going to wind up sitting their ass on the witness chair, and they're going to have a maggot prosecuting attorney saying, oh, well, did you order the haptoglobin test? And, you know, of course, if it's part of your hospital policy, you'll say, yeah, I didn't have to think about it, it was just ordered. Well, let's say you didn't order it for whatever reason, even though you're a good doctor. Well, guess what? He's going to bring in 2 other guys in town that are going to say, oh, yeah, well, I would have ordered the haptoglobin test. And then he's going to say, doctor, you violated the standard of care. Okay, maybe I'm getting a little dramatic
you're
there.
getting too far. I just want to see how you would diagnose it as a pathologist.
Well, as a pathologist, I am very, very biased because all I am is hanging out in the lab all day. I don't have the same access to the patient. You know, we go back and tell you all the time, no matter how fancy your lab is, do a history, do a physical, think, and then order the appropriate lab tests. Okay, guess what? I think we could do a couple more of these things, and let's save iron deficiency for tomorrow because it's the biggest one. And then we'll probably finish up tomorrow, maybe even start with the review or whatever. But Let's talk about folate deficiency megaloblastic anemias, because up until now, I've been talking about them like they're the same, B12 and folate, B12 and folate. There's a little bit of a difference, so let's talk about the difference. They're both megaloblastic anemias. They'll both result in MCVs. They'll both result in anemias, and if I ever learn how to type properly, I'll put that as an N rather than an M. And it's much more likely that you're going to develop a folate deficiency because of a dietary or how do we say this? If you were deprived of both B12 and folate completely in your diet, you would feel the effects from folate much more quicker than B12 because your B12 stores are a lot more than your folate stores. So it's not unusual for a woman, who's pregnant to become folate deficient simply because, that baby needs a lot of the folate. So a vegetarian is more likely to be folate deficient than B12 deficient. You could theoretically have impaired absorption of folate as well. Some drugs, and we'll put anticonvulsants, birth control pills, and chemotherapy on the list, can interfere with proper folate metabolism and therefore cause a folate deficiency. You can lose folate during hemodialysis, and as an increased requirement, pregnant women need more folate than non-pregnant women because a lot of that is going to the baby. And another theoretical thing which I did not expand on is impaired usage, and let's just not say anything about that now. Let's just call it a day. And then tomorrow, we're still have a good amount to discuss. We'll probably skip most of the stuff on coagulation. We'll talk about the mother of all anemias, iron deficiency anemia. By far the most common hypochromic microcytic anemia in the world. And that'll open the door for tomorrow, and we'll see you tomorrow. And thanks for coming. Bye-bye. Could the online people hear and see properly in the second hour today? I need some answers right now. Thank you very much. See you tomorrow. to see if the mother antibodies that would be against those cells. Even if they haven't gone after the cells.
That's not easy. Thank you so much for clarification. This thing always confuses me. Your explanation was
Confused me my whole life.
it was very simple.
Direct cells and indirect cells.
Got it.
Goodbye, everybody.
I'm back home.